Well, this is always great when you're able to spend 6 minutes talking about all the mistakes that you've made. All of these are things that I have learned by hard experience. Kevin asked me to talk about 5 tips to treating these fractures. So I will, for the sake of brevity, sort of just go through them one by one. Tip 1 really is avoidance. And so one of the things that we're starting to realize is that the eccentric placement of the plate on the humerus is a significant stress riser. And when that is combined with eccentric placement of the screw, that creates an incredible torque on your plate bone interface, predisposing you to having a stress fracture at the end of the plate. And so what you're really looking for is a plate that sits straight on the bone and a screw that is placed straight through the bone and that is non-locking. And so that is the construct number 4 that you see at the bottom here, and this is what we're actually seeing the peak forces with. Tip number 2, I think we all know and recognize, but we do it anyway, particularly with distal humerus fractures, and that is having your plates be the same length on the medial and lateral side. And this is easily avoidable, but I think certainly we know that if you are going to need a long plate on your lateral side, then it puts you very close to the radial nerve, so stopping short on the lateral side and going long on the medial side is generally what I choose to do in order to avoid the compromise of the radial nerve and also to avoid stress risers at the end. Tip 3 is to use long plates when you are fixing these fractures. The longest plates that you can find are going to be the ones that you're going to want to use. And one of the little tips that you can do are these little plate extenders, and these allow you to put a short screw in the plate to hold the plate extender into your plate, as you see here. And then they have little holes that allow you to then place eccentric screws around the implant, giving you multiple points of fixation to the plate in a way that you could not do before, and in a way that is probably superior to using the old cables that we used to use. So this is a nice little tip to have. And tip 5 is to use plenty of tibia struts, particularly with your total elbow arthroplasty patients. This is from an article from the Mayo Clinic, and you look, this is Bernie Morey's technique described in the JBJS of using multiple cables and tibial struts to secure the distal portion of the total elbow allograft, and that is something that we make use of a great deal in our revision cases at Duke. So this is a case that illustrates many of the points that I'm alluding to. It's a case of my partner, and I can kind of tell you that this was a very difficult and challenging saga for him. 2014, you can see the obvious stress riser between the plated proximal humerus and the total elbow arthroplasty distally. You can also see the cement that is in the proximal humerus right underneath the plate, so that could be a significant problem in revision cases. Now, at 1.5 years post-op, you're starting to see some evidence of loosening distally, and here she is now with pain and loosening distally. So what do? Again, we've talked about this. This is going to be a challenging problem. You're going to take out the component, and then you have to go all the way up to try to get the cement out. In these situations, it has been shown by Mark Cohen, it's been published, but I can tell you from personal experience, it is incredibly easy to burn the radial nerve, getting the cement out with these. And you have to, even if you're doing it under fluoroscopy, I have burned the radial nerve to a crisp with these. So it can be really challenging, and I would encourage you to put something on the radial nerve as you're working up here to get the cement out. So now you get the cement out, put in a cement spacer, and here she is. There are a variety of cement spacer constructs that are available. I've used them all, right now I'm using a linked Steinman pin that is linked together with a Steinman pin in the ulna and a cement plug around them. Now you can see these custom implants that Zimmer has now devised. It's a way to try to get some bone distally to get some stress on the distal portion of the humerus and build up the bone so that you have something to work with. And so you can see the use of this device in the revision case. And so the endoprosthetic tumor tumor device can then be placed with your struts, as you see here, and that's what that's going to look like 2 weeks post-op. If that isn't getting kicked in the, you know what, there's not much worse. So this is the patient 2 weeks post-op with fracture. So now what? Well, attempted to put the head in the sand again, so this one goes into a fracture brace. 3-month follow-up, maybe. Bone stimulator, maybe. Here she is at 2.5 years with a sufficient bone to allow her to come out of the brace. So you know, you can look at all of these. This is another case, periprosthetic fracture, and right above the tip of the prosthesis. So again, we're going to use the tibial struts and leave it in place. Combine it with a long plate to go up. Patient continues to have pain, and at 7 years post winds up with a through humerus amputation. So you have to be prepared for disasters with these, and I've had more than my share of them. But I hope some of these tips will help you with these. Special thanks to Dr. Bernie Morey, I think, who has given us a great deal to work with these terrible problems. And also thanks to my partner, Mark Richard, who has taken on the lion's share of a lot of these. But they're tough problems. Thank you.